I am Dr. JAYSee, Assistant Professor, Department of Anatomy, Jyoti VIDYAPEETH, Women University, Jaipur. So today we will discuss anatomy of the thyroid gland, and it is the one of the endocrine gland. Thyroid gland is the largest endocrine gland of the body, and the hormones secreted by the thyroid gland are right iodothyronine, and this hormone will indicate it by the T3 symbol. And tetraiodothyronine, that is indicated by T4, and commonly it is called thyroxine hormone also, and calcitonin. So these are the important hormones that are secreted by the thyroid gland. Now we will see the function of the thyroid gland. It will regulate the basal metabolic rate through these hormones, and it will stimulate the mental and physical growth of the body. So that is called psychosomatic growth, and play a very important role in calcium metabolism because it is calcitonin is secreted by this thyroid gland, so it has a very impact in the metabolism of the calcium. So we can see the location of the thyroid gland. So this is the trachea, and this is the neck region. So we can assume the location of the thyroid gland in relation to the trachea. Here also, the thyroid gland is located in the lower part of the front and side of the neck, opposite to the vertebral level C5, C6, C7, and G1 vertebrae, clasping upper part of the trachea. So you can see this is the trachea, and thyroid gland situated here in this way, that is that class to this trachea, and the level of the vertebrae is C5, C6, C7, and G1. Now we will see the parts and features. It is arch-shaped and consisting of vertical right and left lateral lobes and the horizontal isthmus. So we can see this is the vertical part and this is the horizontal part, that is called isthmus because it communicate both these vertical parts. Weight and dimension: thyroid gland weighs about 25 grams, and each lobe of the thyroid gland is 5 centimeter long, 3 centimeter wide, and 2 centimeter thick. The isthmus measuring about 1.25 centimeter in both vertical and transverse diameter. So we can see the dimension of the both vertical and horizontal part of the thyroid. Now the important feature of the thyroid gland is the capsule. Thyroid gland is invested by two capsules. One is inner side and another is outer side, and we can say inner is true capsule and outer is false capsule. True capsule is formed by the peripheral condensation of the fibrous stroma of the gland. So because it is true and because this is a condensation of the fibrous stroma of the gland, and false capsule is thus it is derived from the splitting of the pretracheal fascia. The important fractures of the facial false capsules are: it is a thin and along the posterior border of the lateral lobe and thick on the medial surface of the lateral lobe, and just above the pretracheal fascia after enclosing the thyroid gland is attached to the oblique line of the thyroid cartilage and the body of the hyoid bone in the midline. So why we will say that it is true and false? Because true is because the some part of the gland is condenses to form the true capsule, and false this is a pretracheal fascia, that is the very another structure of the neck region. It is not a part of the thyroid gland, and in true capsule that is a part of the thyroid gland. The gland is roughly pyramidal and present apex, base, and three surfaces. One is the lateral, medial, and posterolateral surfaces, and two border. This is the anterior and posterior border. So it has two borders, that is the anterior and posterior, and the apex is directed upward and slightly laterally. So we can see the apex also here. How this is. So apex, this is the apex. It is directed upward and slightly laterally. It extends up to the oblique line of the thyroid cartilage, and base is extended up to fifth or sixth tracheal ring. Lateral surface, it is convex and covered by the three strap muscles. So these strap muscles are sternothyroid muscle, and superior belly of the omohyoid. We will discuss all these muscles when we will see the anatomy of the neck region. And one is the anterior border of the sternocleidoid mastoid muscle, and these overlapping it inferiorly. Now, medial surface is related to the two tubes. These are the trachea and esophagus, and two muscles are inferior constrictor and cricothyroid. And two cartilage, these are the cricoid and thyroid cartilage. Posterolateral surface related to carotid sheath and its content. So, what are the content of the carotid sheaths? Are common carotid artery, internal jugular vein, and vagus nerve. Anterior border of the thyroid gland is thin and separates superficial and medial surfaces, and it is related to anterior branch of superior thyroid artery muscle. Posterior border is thick and rounded, and it separates the medial and posterior surface. So these are the surfaces and the borders also. Now you will see the relations of the isthmus. Isthmus is horizontal and presents two surfaces. One is the anterior and posterior, and two borders, superior and inferior. Anterior surface related to the strap muscles, that are the sternocleidoid and sternothyroid, and the anterior jugular veins. Posterior surface is related to second, third, and fourth tracheal ring. Now we will see the superior border of the isthmus is related to the anastomosis between the anterior branches of two superior thyroid arteries. And inferior border, along this inferior border, inferior thyroid vein emerges and thyroidea ima artery enters. So this is the important location. Now we will see the arterial supply. The gland is highly vascular. Highly vascular means there are more supply of the blood vessels, and it is supplied by these arteries. Superior thyroid artery. Superior thyroid artery is the branch of the external carotid artery, one of the very important artery of the neck, and it supplies the upper one third of the lobe and upper half of the isthmus. An inferior thyroid artery supplies the lower third of the lobe and lower half of the isthmus. Thyroidea ima artery. So it present in 30% of the cases, 30% of people. It is the branch of brachiocephalic trunk or may arise directly from the arch of the aorta. Accessory thyroid arteries. These arise from the tracheal and esophageal arteries. Okay. Now we will see the venous supply or the venous drainage. So there are the three sets of the vein that drains the venous blood from the thyroid gland. These are the superior thyroid veins. It emerges at the upper pole of the thyroid lobe and drain into the internal jugular vein. On middle thyroid vein, this short and wide venous channel emerges at the middle of the lobe to soon enter the internal jugular vein. Inferior thyroid veins, they emerge at the lower border of the isthmus, form plexus in front of trachea, then run downwards to drain into the left brachiocephalic vein. Okay, now we will see the lymphatic drainage. The lymph vessels drains the lymphatic glands. Uh, these are arranged in two groups, upper and lower, and they follow the arteries. The upper group drains into the prelaryngeal and upper deep cervical lymph nodes. The lower group drains into the petechial and lower deep cervical lymph nodes and group of lymph nodes along the recurrent laryngeal nerves. So we can see in this diagram these are the lymphatic glands where the lymph drains into these lymph nodes. Okay. Now we will see the nerve supply. This thyroid gland is supplied by both sympathetic and parasympathetic nerve fibers. Parasympathetic supply is derived from the vagus and recurrent laryngeal nerve, and sympathetic supply is derived from the superior, middle, and inferior cervical sympathetic ganglia. Now we will see the very important clinical condition of the thyroid. We will see in day-to-day practice, clinical practice, these conditions are must we will see, we can say there are more type patients come uh, with all these complaints are related to the thyroid gland as goiter. How we will say the goiter? So if there is any enlargement of the thyroid gland except that during menstruation and the lactation is called goiter, may be associated with the hypofunction and hyperfunction of the gland. Hypothyroidism is the most common complaint in females when there is insufficient secretion of T3 T4 hormone. The decreased level of T3 and T4 cause increased secretion of the TSH. Simple goiter, and we will see puberty goiter. It is the enlargement of the thyroid gland without sign of hyperthyroidism. It occurs due to deficiency of iodine in diet. Remember, iodine is very essential for synthesis of the thyroid hormone. The decrease the level of the T3 and T4 led to increased secretion of TSH from the pituitary gland. The TSH causes hyperplasia of the thyroid gland. Simple goiter commonly occurs in females at the age of the puberty, hence it is also called puberty goiter. Now the effect of massive enlargement of the thyroid gland. So the important effect of this enlargement, they will compress the surrounding tubular structures and they will give some characteristic symptoms like dyspnea, dysphagia, and dysphonia. Benign tumors may compress or also displace the neighboring structures, whereas malignant growth tend to show invade surrounding structures also. So these all about the anatomy of the thyroid gland. Thank you.